So this section is called Cure for All, Innovation for Affordable Healthcare. It is chaired by Dr. Arvind Lal. Access to healthcare remains a challenge for much of the humanity. Many cannot afford appropriate diagnosis, medicine, and care. It is a challenge for innovators to meet this fundamental need in every society. Technology must be leveraged to develop new healthcare models that can increase productivity and affordability of medicines, devices, hospitals, and healthcare professionals. The innovations must overcome the constraints and costs of distance, infrastructure, and intellectual property. How can the critical medical devices be made more affordable and portable? How can diagnostics reduce the need for expensive healthcare? What role can IT, automation, and artificial intelligence technologies play in making healthcare more accessible and affordable? These are the questions that will be explored in the next session. I will turn it over to Dr. Arvind Lal, who is with a keynote address from Dow Wilson, President and CEO of Varian Medical Systems, and closing and concluding remarks by a professor at Haas and Ganesh, Iyer, Professor of Business Administration, Haas School of Business at UC Berkeley. Dr. Lal.
Good afternoon, ladies and gentlemen. So it's my proud privilege to be here today, and I thank All India Management Association for bringing me here. And I also have the pleasure of welcoming Mr. Dow Wilson, President of and CEO of Varian Medical Systems, and Professor Ganesh Iyer from the Haas School of Business, University of California, Berkeley. We are privileged to have users, and Mr. Dow Wilson is the President and CEO of Varian Medical Systems. His company is one of the major innovators of medical devices, particularly in the areas of cancer. Mr. Wilson, thank you very much for joining us, and a very warm welcome to you, sir. We are also privileged to have Professor Ganesh Iyer of Haas Business School in the session. He is the Edgar F. Kaiser Professor of Business Administration at the Haas School of Business. Professor Iyer, welcome to you, sir. Thank you for being here. Ladies and gentlemen, access to healthcare is as important as life itself. Still, despite the perennial promise, the dream of universal healthcare has always run into the wall of economic reality. However, advances in technology give us the hope that we will be able to save every life and keep everyone healthy. So just at this juncture, I would just like to give you a snapshot of what the Indian healthcare scenario is. You all know that the population of India is touching nearly 1.3 billion, and nearly a very large population, I wouldn't like to put my finger on the percentage, about 65 maybe, our population is still earning less than $50 a day. The total spend on healthcare is about 4%, and out of which the government of India spends a very small amount of 1.4% only. The government, however, has now promised to increase the health spend from 1.4% to about 2.5% till 2025. The three basic problems in Indian healthcare are those of accessibility, affordability, and quality. According to the CLSA report dated 6th September, that's just a few days back, the private sector has a higher share in providing health care of inpatients I would say 80% of the doctors are provided by the private health providers, 78% of the OPD services, 60% of inpatients, 63% of beds, and 70% as a value proposition of the market. India has a dual disease burden known as communicable diseases, which include diseases like malaria, dengue, chikungunya, tuberculosis, which still is India's #1 communicable disease. We have the world's largest, burden of TB patients, nearly 2 million of them. And every minute in India, we lose one patient from tuberculosis. On the other hand, we also have the non-communicable diseases, which are responsible for the death of 65% of Indians. So these are led by diabetics, which are nearly 70 million, about 120 million of hypertensives, 3 million of cardiac, and 3 million cancers, and so on. So folks, it's no wonder that new technologies will make it possible to stretch our capabilities at both ends. They allow us to create cures of unprecedented sophistication when the price is not a factor, and they also allow us to create cures of unprecedented simplicity when price is the most important factor. The information and communication technologies are already addressing the cost issues created by distance of healthcare facilities and loss of income due to time away from work. Today, it is possible to diagnose, monitor, and counsel remotely. Today, doctors can collaborate on treating patients across the world using the internet. Wearable and home diagnostic services or diagnosis services have empowered patients to take charge of monitoring their own health and sharing data with their doctors using mobile phones and other technologies. Today, it has become much easier to find and compare doctors, hospitals, and insurers using healthcare information apps. Now, advanced automation holds the promise to lower the cost of healthcare despite initial expensiveness of the research and development. Learning machines and artificial intelligence are digesting historical healthcare data, and they could potentially make diagnosis and treatment information available on places like Google and IBM Watson and many others. Robotics are speeding up operations and allowing doctors and hospitals to do more than they could do earlier. According to a McKinsey report, big data has the potential to save hundreds of billions of dollars every year in healthcare by optimizing patient care. Big data would allow early and effective detection and treatment of illnesses. It also points out that the use of surgical robots with open source software would allow lower cost surgery and telesurgery. The key to making quality healthcare affordable and accessible to all, in India especially, is putting the patient first and focusing on the unique local conditions. Typically, innovators chase the high end or the high-end urban markets for quicker returns on investment, which is naturally so. That pretty much puts innovations out of reach of the majority of the population in developing countries like India, where electricity, clean water, and broadband internet are still not pervasive, and where typically the conditions are dusty, hot, and humid. Therefore, medical innovation must both be frugal and all-weather compliant. In fact, frugal innovation is as relevant to the developed countries as it is to the developing ones. In many developed countries, universal health care is still a challenge because of the way innovation incentives are structured and the way medical bills are paid. India is a great laboratory for frugal innovation for the world. India has both the best of healthcare in the world and also near absence of healthcare in some parts of India. Distances and shortage of infrastructure are major challenges in the rural areas. Much of the population has trouble paying medical bills, and many still rely on traditional medicines and go to a hospital only as a last resort. So it is only natural that India innovates. Remote diagnosis and counseling is growing, and Delhi health insurance payment schemes are created. Labs are providing test results on the mobiles, and doctors are providing post-test advice on social media apps, which saves the patient multiple visits to the labs and hospitals. In a country like India, smartphones are going to play a key role in making healthcare affordable. Early and accurate diagnosis is critical, as is the post-care monitoring. For example, camera phones can be used for diagnosing and advising treatment for many superficial ailments. The sensors in the phones and apps can be used to monitor cardiac signals and blood pressures remotely. India is currently seeing exponential growth in data access coupled with affordable smartphones. These are precursors to startups that will revolutionize the healthcare sector by creating localized solutions. Affordable healthcare is as much a creative challenge as it is a technical one. Often, a non-linear approach is required to come up with frugal innovation because there is no point in asking the typical doctors what they want because they would seek incremental improvements in the existing products. Disruptively, frugal development is an area for the startups. There is tremendous amount of experimental work going on in the US, startups and universities. One lab in the US, for example, has made nebulizers from cycle pumps and sterilizers from pressure cookers. Another has created a foldable paper microscope for detecting pathogens in blood and a paper fuge for isolating malaria parasites in the blood. India's own startup sector is beginning to see action in the healthcare space. Though Indian healthcare startups have received a minuscule level of investment compared to e-commerce, fintech, and taxi services, they are gathering momentum now. The most successful healthcare startups in India so far are in the areas of healthcare information, home care, cancer, and genomic diagnosis. According to a KPMG study, Indian healthcare startups could attract as much as $25 to $30 billion in the next 5 to 6 years. Currently, a major chunk of Indian health tech startups are only focusing on booking of doctors' appointments, of getting medicines, getting lab tests done, and going to hospitals, etc. This is going to evolve to healthcare management, rural healthcare, and wellness over the next decade. There is plenty of room for collaboration between the Indian and the American researchers in the area of affordable healthcare. India could use the latest healthcare technologies and designs being developed in the Silicon Valley, while Silicon Valley could use the field of testing opportunities available in India. Collaborative development is the perfect way to create technology-enabled solutions with great affordability. For example, I was discussing with Mr. Dow Jones that just imagine a patient who comes to me with a high fever. He could be suffering from, sorry, so that's okay. So a person could be suffering from malaria, a person could be suffering from typhoid, he could be suffering from any of the infectious diseases like hepatitis, chikungunya, etc. So in the land of Silicon Valley, just imagine if you made a chip which had all these kind of ingredients with fluidics and nanotechnology and with PCR capabilities, we could probably save a lot, many more hundreds and thousands of patients in India. Stanford India Biodesign is a good example of such creative partnership. Stanford is working with Indian Institute of Technology and All India Institute of Medical Sciences, and the program allows Indian engineering and medical students to spend time in Palo Alto learning about the cutting-edge medical technology and designs and assess its relevance to the field conditions in India. While innovating to find better solutions to healthcare issues is important, it is also equally important to innovate with a target user and at a target price. In fact, the volume market is always in the lower half of the pyramid, and the innovators who address that will make a lot of money. We are fortunate to have the CEO of a company that innovates for both halves of the pyramid, and it would be quite interesting to hear what he has to say about affordable healthcare. So it's now my pleasure to invite Mr. Dow R. Wilson, President and CEO, Varian Systems, to address the conference. Mr. Wilson.
Introduction, can you hear me okay? Thank you for that nice introduction. I guess I get to kind of be our transition to reality after this morning's big, broad views and the inspiration we heard from our speakers this morning. We get to transition to more mundane problems like how do we cure cancer. So with that, let me talk a little bit about what we're doing in India. First of all, just a word about Varian. You probably don't know us. In fact, you have a 1 in 7 lifetime chance of knowing us. Globally, 1 in 7 cancer patients are treated on our machines. So we're the brand you don't want to know. But our vision is to create a world without the fear of cancer. That's who we are. We do this with linear accelerators. That's what you see with the patient sitting on the table up there. 60% of the accelerators in the world are our accelerators. We produce a personalized plan that delivers radiation to a tumor. Radiation is not, as many of you might think, an ablative process. It's actually a biological process. We give just enough radiation to the tumor that the DNA collapses and the tumor is destroyed. We treat about 3 million patients a year. We are probably a recent study has us as the 8th largest healthcare information technology company in the world. So we're doing that largely in cancer as we try to bring information technology to bear with artificial intelligence and knowledge-based systems on the problems of cancer so that we can treat them better. Why can't you get the same level of cancer therapy in a village in India that you might get in Toronto, New York, or Houston, 3 of the top cancer centers in the world? We spend about $250 million a year in research and development in trying to accelerate the pace of change in cancer. You know, when you look at India, there's a number of factors that contribute to the high cost of care. You know, as has been pointed out by Arvind, there's a growing recognition of the need to move resources to non-communicable diseases. Last 50 years, been working very hard on communicable disease. And the good news is, across the world, we've made great progress. I was on President Obama's Doing Business in Africa Council, and one of the really inspiring stories is, guess what the #1 leading killer of women in sub-Saharan Africa is now? It's cancer. That's bad news, but it's also good news, because that used to be #7. And just a decade ago, it was way down the list. So this is the kind of progress that we're making across the world in solving the burden of communicable disease. But as we solve that, we generate another problem, which is we have not yet figured out this curse called mortality, and we will die, and that comes from non-communicable disease. Of course, the referral system in India and a lot of these geographies is therefore built around a system of communicable disease and isn't quite tooled up for all of the referral services, tertiary services, advanced clinical care in both equipment, services, and people that are required to deliver against that burden. This is in transition, but there's been low public expenditure on these diseases. The good news is there's been a proliferation of public hospitals, but not so much with the kinds of services to take care of these advanced diseases. And of course, they're expensive, they're hard to use, which leads to quality issues, and all this kind of yields a high cost scenario. All this in an environment where policy moves by the minute. You know India better than I do, but there's a ton going on as we move towards an environment where we're trying to bring health to everyone. The good news is there's increased collaboration with the private sector. There's more and more models for looking at creativity where government and private sector can work together. There's a push. Some of it's good, some of it's not, but the push for lower cost is right on. The push to you have to be local to participate isn't always a good thing, and may not always be the lowest cost thing either, but made in India in terms of getting some of the cost out is certainly a positive thing by itself. And then of course this, won't talk about everything here, but the increased focus on streamlining regulation is very, very important. We still have a long way to go. The good news is there are countries in the world that are slower than India, but for us, the regulatory cycle in India is at least 50% longer than what it is in the US and Europe, which are among the slowest in the world. That's an area where we still have, if we're going to get a real innovation cycle in India for healthcare, we've got to look at what we can do to streamline some of the regulatory policies. Good news is there's been a lot of innovation around some of the models in order to lower care. Here's just a few examples. Dialysis has taken the cost from $47 to $15 a treatment. You see an example here with generic medicines. There's telemedicine has already been referred to in oncology. There's some very exciting examples where, how do you keep the expertise centralized, and then in a telemedicine world, put the equipment and the resources that you need to actually do the work remotely, but leverage kind of a hub and scope concept to lower the cost dramatically and get the service to the patient where it's needed. So there's been some nice examples of some kind of disruptive things that are really dramatically lowering cost. Of course, as it relates to cancer, we have a long way to go. You can see between 2014 and 2020, the disease burden of cancer will double in India in just these 5 years. You can kind of see the services that are estimated or required. So in cancer care units, going from 250 to 500 cancer care units. And now just kind of think about that burden in terms of what it's going to mean for the intellectual requirement that we have. The cancer care professionals are going to go from 2,000 to 8,000, postgraduate seats from 22,000 to 40,000. The number of linear accelerators, what we do, from 350 to 800-ish. You're talking about a doubling of every resource that we need to just make, frankly, some fairly minimal progress in the kind of access that we need to address the need for cancer patients. One of the issues we have, one of the vital technologies of diagnosing cancer is a PET CT scanner. You can see there, PET CT scanners are concentrated in 40 of the 640 districts in India. So we've got to that's an example of where the technology has got to diffuse. Maybe the people don't. And so how do we leverage knowledge-based systems where we can get the technology where it's needed, but keep the expertise and maybe minimize some of the human resource, because that's our biggest challenge. Medical schools are just not turning out this level of resource. When you look at our particular field, there's, as I mentioned, there's 350 linear accelerators in China. They are also only in 40 of the 640 districts. A third of those are in metropolitan areas. Good news is there's started to be some diffusion of product into rural areas. But the kind of comparison in terms of a need point of view, you can see here on the right, China is at 0.7 Linacs per million people. India is at 0.3. It's interesting, when I started at Varian in 2005, we did $5 million in India. That same year, we did $13 million in China. This year, we'll do 100 to 125 in India, and 250 to 300 in China. I think the big difference is both markets from 2005 to maybe 2010, 2012 were largely private. You know, the middle class was growing, the upper class was growing. They wanted services. As the volumes came, resources were put in place, and actually very good. You know, some of the best care in the world today is in India. But it was not very diffuse. And of course, that's been what we've been working on. US, in terms of LINACs per million, is probably at 12, and Western Europe's at 6. You know, so you can kind of see the big difference in access to care and this very significant path that we've got to go. So kind of how do we do it? You know, first of all, if you're in healthcare, you got to think about the problem broadly. You know, we'd love to think about it as an equipment problem, and I'm going to deliver you a linear accelerator and good luck. Well, that's not the world. As my father would say, fish can't complain of the sea being wet. And so, you know, what do you have to do? You know, there is a technology aspect to it for sure, but training and education, patient care, long-term partnership, financing, different business models. There's a whole bunch of things that we have to make sure we're thinking about on the way to delivering new services into these kind of markets. So one of the things that we've done in India very successfully, some public-private partnership initiatives with different states. Those have been very long-term, lower the capital costs, spread out the cost over time, enables a whole bunch of people to get into a capability that they have not historically been able to do. One of the things that is very expensive in our field and is a good example of kind of some of the things that you can do to lower the cost is really think through this hub and spoke. The biggest challenge we have is treatment planning. So each tumor for a cancer patient is treated with radiation, and about 60% of cancer patients are treated with radiation. Each tumor gets a personalized treatment plan. That personalized treatment plan is done by a physician and a physicist. If we can centralize those physicists and physicians, give them artificial intelligence, and then deliver the plan locally to where the resources are, maybe we don't need 2,000 to 8,000 kind of increase in the number of physicians that are going to be required to deliver the care. And can we do that and deliver the same kind of care that you get at MD Anderson or Memorial Sloan Kettering or Princess Margaret? That's our challenge. And we feel very positively. We have a number of pilots going on in this in India today, where that's being centralized. You can put the resource out more locally and keep the very expensive people side of it more centralized. A big part of it, of course, is the technology itself. Many of you have heard of this concept of reverse engineering made famous by GE. In fact, I was the guy who did the first 2 GE projects in the late 80s and early 90s with a CT scanner and an X-ray system working for GE Healthcare. That was made famous by Jeff Immelt and VJ in the famous book they wrote on reverse engineering, where you developed a product to meet emerging market needs, really talk about how you achieve a highest level of quality at a cost point that is very disruptive, and then take the product globally. So that's what this product is. We just introduced it earlier this year. We're very excited about this product. Some of its highlights, it requires about 2/3 of the electricity to run. Turns out that a linear accelerator, what we do is convert electricity into radiation and then shape it to a tumor. That's kind of technically what we do. But we're the biggest user of electricity in a hospital, and this product reduces the electrical requirements by about 2/3. All of a sudden, it brings all kinds of options for reliability of electricity, solar, other green approaches to powering the system into the market. It requires only 1/3 of the cement to shield the system. People can get their centers up and going much, much faster at much lower cost. It reduces the number of steps to complete a radiation treatment plan from 31 to 9. And then one of the really cool things we did on this product is the way the radiation is shaped is much, our customers would call it much more conformal So there's much less radiation dose to healthy tissue and much more tumoricidal dose where we want it. So very, very exciting product. An example of collaboration, in this particular case, of engineers in China and India working together, built, in this case, in China, and sold globally as we meet that need. So, you know, again, big focus on operational and capital efficiency to lower the service cost, the product cost, the infrastructure cost, the human requirement, bringing a lot of artificial intelligence and knowledge-based tools to the treatment planning. And then, of course, on the management side and the financing side with PPP models and other kinds of business models to help customers adopt the technology quickly that they can make an impact fast in the market and have an impact on public health. So I'm not going to go through all these. So, you know, just in conclusion, you know, advanced technology is increasing cure rates. It's kind of amazing. In my career, you know, I've seen 5-year survival rates in breast and prostate cancer go from 50% to 95%. You know, it's we still have a long way to go with lung cancer, liver cancer, and pancreas cancer, glioblastoma. You know, there's still a number of cancers that are very, very lethal. But we're making progress in those cancers as well with our clinical partners. And of course, it's not just radiation, it's geneticists and chemotherapy and surgeons and a whole slew of tools that are making the difference. But you know, advanced technology really has something to offer. With that, it's clear that we can advance the technology and improve access through affordability and really, you know, I'd say one of the big issues of the last 50 years in healthcare has been the distribution of care around a mean, if the mean is the standard, has been very, very wide. And, you know, can we deliver a very high standard of care everywhere in the world? You know, that's our challenge as we bring access to these markets. We just don't want to bring the tools to the market, but how can we bring the finest care possible? And then, of course, on the way, enabling new business models to make it affordable and accessible for governments and healthcare providers to enable the service in their environments. Let me just say that, you know, doing this now for 35, 40 years, it's been a blast. You think, you know, sometimes I get asked the question, you know, aren't we getting close to the asymptote? You know, and I guess I would say, you know, we're further away than we've ever been. You know, it's never been a better time to be in healthcare, to be in cancer care specifically. There's been a ton of innovation in the last 50 years, but I think we're, with a lot of the things going on, we're on the cusp of many, many exciting innovations to come, and it's really a blast to be a part of it and to see the kind of opportunity that there is for India to make a difference in that is also very exciting. Thanks for having me today.
So thank you very much, Dow. And we'll have the question answer session after Professor Ganesh Iyer has given his remarks. Professor Iyer is the Edgar F. Kaiser Professor of Business Administration, Haas School of Business at University of California at Berkeley. Formerly a faculty at Olin Business School, Washington University at St. Louis, he is a PhD from University of Toronto. An award-winning researcher, he is the senior editor of Marketing Science and has been an associate editor of Management Science and Quantitative Marketing and Economics. He studies marketing strategy issues and writes about product distribution, market information, internet strategy, strategic communication, and bounded rationality in marketing strategy. May I request Professor Iyer to deliver his concluding remarks, please.
So thank you, Arvind, for the kind introduction. And it's great to be here to listen to Dow and to his overall view of healthcare and healthcare innovations and how they may be relevant for the Indian context. So listening to him, there are at least 4 overall themes that came to my mind, which can be important and central to the way we think about the distribution and the dissemination of healthcare to the vast underserved market, especially the rural markets in India. So the first point that we might want to keep in mind when we think about innovation in terms of improving the delivery of healthcare is thinking about how to integrate public-private partnerships, how to make use of not only the existing government program, but work proactively with what the vision of the government is in terms of investments into healthcare. That's number one. Number two, a country like India, innovation and healthcare innovation in particular has to be focused on frugality, as Arvind had mentioned in his introductory remark. So how do you reduce delivery costs? Okay? So you may have a great technology, but it's important to think about how to take that technology to the consumer. Okay? So that's the second overall thought or theme that comes out of Dow's talk. The third is that technology is just the start, right? What we need to have is a total systems view, right? So you may have a medical device or a technology which is a solution, which is a therapeutic or a clinical solution, but we also need to think about the total system, that is training and education. How do you enable the technology to be used in the most wide kind of manner as is possible? Okay? The other is, for example, compliance. So how do you ensure that patients comply with the treatment that they get and the post-treatment behavior that is expected? And then finally, how do you use, and as he mentioned, the hub and spoke model to take hospital care and radiate it out to markets which are not well served? So given these 4 themes that I picked up from his talk, let me just make a few overall comments on healthcare delivery in the Indian context. Right? So it's very clear that India is a large underserved market. Okay? Why? Because if you look at the demand side, okay, think about healthcare spending, okay, we are quite some ways behind not only the developed countries such as the US or UK, but also China. And more importantly, the $250 equivalent PPP spending per capita is mostly out of pocket and rural. Right? So we have some ways to go in terms of healthcare consumption. On the supply side, there is a large shortfall in healthcare infrastructure, and in particular in doctor capacity. Right? So we are at, say, about 0.6 doctors per 1,000, as opposed to, say, China, which is at 1.5 doctors. And there again, there is the rural-urban disparity where the concentration of doctors is very high in mostly urban areas. So when you put all these things together with the overall growth story that we talk about, the 7, 8, or 9% growth over the next decade, what we can expect is large demand or expected demand in healthcare consumption, okay? And leaving behind a pretty large underserved market, and especially large underserved rural markets. So, what that brings me to is to think about innovation not just as innovation in technology or in solutions, but innovations in delivery. Okay? How do you take an existing technology to the market and make it available in a manner that you take advantage of the underserved market as an opportunity? Okay? So I have 3 overall thoughts on that. Number 1, we can think of innovations as innovations in portable and reliable medical technology, which has 2 properties. 1, which can be deployed to underserved markets, which are more remote, and 2, which are potentially usable by trained secondary health personnel. Right? So that's number 1. Number 2, delivery and diagnostic innovations. So how do we use the web or video as a delivery mechanism for, say, consultation and diagnostic services? Okay? How do we use the significant penetration of smartphones in the population to improve interface or interaction with patients? Okay? Then finally, we can also think of innovations as enabling major hospital systems, say in urban centers, to be able to radiate out into smaller markets and into rural markets. Okay? So the call here is to think about innovations not just on the technology side, but also solutions which enable better delivery and reach. Okay? So those are my kind of overall thoughts, adding on to what Dow has presented. And so I think that's about it. And thank you very much for being here. And I guess I will open the session up for questions.
So thank you very much, Ganesh. And before we conclude this session, we have time for about 2 questions. Sorry, we're running out of time. So anybody would like to ask any question, most welcome. Yes, please. There's a gentleman at the back.
One question I have is, there's one big challenge in the healthcare industry. There's a lot of focus on advanced research on, I would say, rich people's diseases, but not enough on prevention, one, and secondly on the poor man's diseases, be it all those diseases of Africa or the poor parts of India. So any views on that as a healthcare industry?
I'll take a shot at it, not being an expert in that, but just from my perspective on President Obama's Council on Doing Business in Africa. There's been huge progress made on communicable disease across the world. So when you look at smallpox, malaria, AIDS, basic fundamental infectious diseases in sub-Saharan Africa, the Amazon, et cetera, there's been really quite significant reduction in improvement in life and reduction in mortality. So that's been very impressive to see. We still got a long way to go. I mean, that this is not over. It's, I gave you the example of Ghana. In Ghana, in women, cervical cancer is now the #1 killer of women in Ghana. This is good news and bad news. Good news is the other diseases that have been the issue in the past, we've gotten a pretty good handle on. Bad news is cervical disease, cervical cancer is a disease we can treat, and there's all kinds of social issues around it in Ghana. There's no way that cervical cancer should be the #1 killer of women in Ghana. So it's transitioning quickly, and populations are demanding it, especially as they urbanize and as education happens for them. So we still have to do both would be my answer, but certainly what we're seeing across the world is a inexorable but positive improvement in the management of communicable disease and a growing burden of non-communicable disease like cancer and cardiac issues, so vascular disease.
So,
Mr.
the
Wilson,
gentleman at the back.
question for you, Mr. Wilson. The machines that you're talking about making with less concrete and less energy and all, are you concerned about patents and how are you going to protect those? I mean, you're saying China and India. You're a private company, right? You want to make some profit, right?
The short version is yes. The long version is we do a lot.
Sorry, we
to
are running
manage
out of time, so we have just 2 more questions. Yes, gentlemen there.
So while you talked about the hub and spoke model, you talked about the public-private partnership. My question to you is, I just think the kind of a model working where you did not have the government as a country between your end by delivery, where you directly approached to the end customer and patients for delivery of the healthcare services without facilitated by the government, because or through the NGO or through the civil society.
Yes, I think there's been many examples. I can't think of one off the top of my head in India. Yep, there's even been a couple examples in India. I wouldn't say directly with patient groups, but with providers. Just see me after.
Okay. Gentleman on the right side, please.
But my question was in terms of, cancer has become a major killer lately with all the ongoing challenges we have with water, pesticides, and all these impacts that is currently ongoing with the food industry. But what kind of analytics data are you collecting to make sure that you are able to go out and address these challenges, do the root cause analysis, and actually make a dent in terms of making those wins happen for us?
Our business is the treatment of cancer. So we are not on the diagnostic side. This will be a little bit of a cop-out. We're not a diagnostic company. But once you're diagnosed with cancer, what we want to know is, can we treat it better than anybody else? And can we give you the cure and the lack of toxicities and side effects that you deserve? And so that's where our analytics are all designed. Because one example of the kinds of things you're talking about, it is estimated that there will be more lung cancer burden in China alone in 2030 than there is burden of cancer disease of all disease types in the world today, and that's all air quality, and smoking. So the how are we going to take care of lung cancer in these kind of epidemic forms? It turns out that radiation's a good tool. There are all kinds of other tools used for lung cancer. But one of the problems with humans is they breathe, so the target moves. So we have to be able to deliver the radiation dose and not hit any of the other moving lung. Anyway, so those are the kind of analytics that we're building. They're really more on the therapeutic side.
So thank you very much. One last question, please.
Yeah, thank you very much. This is really for Dr. Lal. India, I know we've talked a little bit about distribution for some of the therapies and diagnostics, but you've built a tremendous company in a very large and complex country. And I wonder if you could just share with us one morsel of how it was that you've been able to build this out, sort of from an operational corporate side, from an entrepreneur business family perspective? If there's one key ingredient that made this work.
In my humility, what I'd like to say is that I just did the right thing at the right time. First of all, my father had started this lab in 1949. He passed away in 1977. That's when I took over. And then I just grew. Auto analyzers were coming my way. Computers came in '86. I was the first one to do that. I innovated in my own way. Nobody would give me 250 square feet of space for a collection center. So I got the first franchising in healthcare done in the world. I offered him something from the top line and refined that model. Now we are running 1,600 collection centers, so on and so forth. So just in 2005, then we got some private equity in, and I had been looking for a CEO for a very long time. And CEOs don't like to join mom and pop shops, as you know. So I had to convince him that, well, I wasn't such a bad guy, and I never looked back then. Thank you very much.
Thank you.
Thank you, and moment will be shared by Pramod Basin at the moment, and then we'll move on to the next section. Yes, as you're settling down, one of the things I just want to give my 2 cents on this healthcare last mile. In the smart villages, we're experimenting with a business model solution to incentivize the delivery of healthcare to the last mile. Without a business model, nothing works. Government programs do not work, schemes do not work, handouts don't work. So without the government, we have working with 2 of the largest institutions, Apollo hospitals and care hospitals, and we tell them there's money in it for you, but how do you deliver the value to the poor man where masses live in the last mile? We have created, we are using technology. It is a laboratory on an auto that goes, used by the RMPs, that goes down to every home, collects data, pushes it to the cloud. It does every test possible except X-ray. And then the Apollo hospital, as well as the care hospitals, come to a hub close by, looking at the data and saying, well, so many cardiologists are needed here, so many dermatologists are needed here, so there's money for them. So it's a business model approach. And they signed up for it, and we'll report to you the results of that approach, because it seems there's money in it for the ecosystem for it to prevail. And that's what we're doing. We're using technology, but the Uberization of this model. This equipment costs 2 lakhs. The RMP cannot afford it, but it is given to the local primary health center, and it is rented by the RMPs by the minute. So the equipment is used all the time. And it's a business model approach, not CSR, not government program, not schemes. And we'll report on it, and some of the big companies are working with me on that, so we'll report to you the results of that.